The concept of allowing euthanasia in human medicine is a very complex issue with many sides, unanswered questions, and unknown paths. However, we should not let this deter us from looking into the possibility of allowing euthanasia for certain patients. According to the BBC, in 2015, 5 U.S. states allow doctors to aid terminally ill patients through assisted suicide. Globally, the Netherlands, Belgium, Switzerland, Colombia, and Canada all have legislation allowing for either euthanasia or assisted suicide. Penny Lewis, a reporter for the BBC, reports that in the Netherlands, euthanasia rates have remained steady at 2.8% of all deaths in 2010, whereas in Belgium, rates have steadily risen since 2002 to 4.6% as of 2013. Personally, as an individual working in the veterinary field, I have been able to view euthanasia from a unique position. The majority of people in the field, including myself, view euthanasia as a gift we're able to grant our patients to ease and end their suffering. Personally, whether right or wrong, I feel that euthanasia should be an option. Making the transition from animal to human medicine, though, you do run into a number of ethical questions and potential issues. However, there comes a point in one's condition that the suffering through treatment or management is no longer the best medical option. In Karen Shakard's article, A Dying Man's Wish to Donate His Organs Gets Complicated, Mesrich states that doing no harm doesn't always mean making people or animals live as long as possible, keeping them alive no matter what. And going off of this, I'm going to explore 3 cases. The first one going back to veterinary medicine. In this case, we're exploring in what instance euthanasia may be an option in veterinary medicine. A 6-year-old collie was presented at a veterinary clinic to treat a recurring ear infection that wasn't responding to treatments. After further inspection, the practicing veterinarian found masses that were expressing fluid, causing what was initially thought to be the ear infection. Surgical removal of the masses was pursued, and the surgery went smoothly. The patient was prescribed an antibiotic and pain reliever for 12 days following the procedure, and the dog seemed to be making progress. After 2 weeks, the patient began regressing to what appeared to be another ear infection. Upon closer inspection of the ear, another mass was forming and coming back more quickly than initially. A month after the first surgical removal, the patient was transferred to a surgical specialist to remove the entirety of the mass. After examination by the specialist, and looking at the rate at which the mass reemerged, he suspected a malignant growth within the ear canal and ordered a mass biopsy to see if surgery would even be an option. The biopsy came back as a squamous cell carcinoma, a malignant growth. With a clear x-ray and the biopsy results, the next treatment option was a CT scan to see if radiation therapy would even be a viable treatment option. The owner chose not to pursue the CT scan due to the cost, and the high possibility that such a treatment wouldn't work, and would likely decrease the patient's quality of life further, with little chance of living longer than a year afterwards, even if the treatment was successful. The patient was managed with an antibiotic and 2 painkillers. For the first 3 weeks on the medication, the patient improved greatly, and seemed to be well managed. However, the mass continued to grow rapidly, and continued expressing fluid. Over the course of the next 3 weeks, the patient got progressively worse, as the mass began pressing on her brain. And with the very bitter antibiotic, she began to refuse food, the only way that the medication could have been administered. The patient quickly deteriorated to the point where she was no longer willing to go outside. She could no longer walk well, and was not cognitively aware. Due to the grim outlook of the case, treatment paired with the patient's age, the owner was largely faced with one option, as to not prolong the patient's suffering further than had already been done. If the above patient had been human, she likely would not have been allowed euthanasia. Instead, she would have lived an incredible amount of pain, with the mass pressing against her brain. Now granted, a human patient would have received the CT scan, but that would not have increased the chances of it being a treatable case. The patient would have likely been subjected to pain for a longer amount of time than was reasonable to say for a few more months before the inevitable outcome. In the instance of veterinary medicine, where the patient does not have any say in the outcome or course of treatment, it is left up to the owner to make the decision. In the instance of human medicine, it would only make sense that the individual of a sound mind and with a terminal illness should be able to make that call for themselves. However, in an instance of brain death or inability to fully communicate, it should be a decision made by the family, with certain legal oversights to ensure no malpractice. The second case involves Dave Addicks, who was diagnosed with ALS and lived for 2 years after the diagnosis. He made the decision with the support of his family to end his life in a hospital in order to fulfill his wishes to donate his organs. Addicks was arguably of sound mind and had agreement from his family for his choice to be taken off the ventilator that was helping sustain his life. Addicks' case resembles more an assisted suicide, in that he made the final decision prior to going under sedation. Addicks' case is a good example of location hindering the outcome he and his husband had wished for. The complexities of the case kept Addicks' primary physician's hospital from comfortably allowing Addicks to be admitted into the hospital solely to be disconnected from the ventilator. Dave Addicks had the moral authority to choose when and how he was to pass. The hospital that Addicks eventually was admitted to initially faced the same issue that Addicks' primary hospital ran into. Initially, they could not honor their patient's request. And Shakeridge's article states that the experience prompted physicians to develop a multi-step system that includes evaluation from psychologists and an ethics review and considers technical matters such as transportation or insurance coverage. There is no reason that an individual with sound mind facing a terminal illness shouldn't be able to say at what point they want to say goodbye. The family should also be given some say in the ultimate decision, as it is one that will also affect them. All parties involved, the individual, the family, and the physicians, had a say in the outcome, thus making the act of euthanasia well applied to human medicine. In the third case, the decision to pursue euthanasia or assisted suicide cannot always be made by the individual whom it affects most. Aruna Shanbhag is a very good example of the issues surrounding euthanasia. Shanbhag, following an assault according to an article by the BBC, was left with severe brain damage and paralyzed after the 1973 attack, and was unable to make the ultimate call to end her life. As a result, she spent the following 42 years having to be force-fed through a tube in order to sustain life for as long as possible. In this case, with the passing of Shanbhag's parents and no other family remaining in contact with her, there was no ideal way to pursue euthanasia. Realistically, the only real way in which a path towards euthanasia could have been achieved was through a conditional law or court order assessing quality of life in relation to the likelihood of recovery for Shanbhag. However, in a case such as this, you do open the door for more mistreatment of such a law or court order. This concern prevented India from passing any sort of euthanasia bill to allow Shanbhag a peaceful, quick passing, as there was no one legally able to speak for her, and in taking such an action themselves, the government would likely have lost a considerable amount of public trust, in who they would choose to deem worthy members of society worth maintaining life. In conclusion, one counter-argument against allowing euthanasia is found in J.K. Williams' essay, The Wrongfulness of Euthanasia. He states that doctors and nurses are, for the most part, totally committed to saving lives. A life lost is for them almost a personal failure, an insult to their skills and knowledge. While for some this is true, and a life lost is never a celebration, in my experience, doctors and nurses acknowledge that not every life can be saved. While continuing to try their hardest, there is some peace in knowing that you have done everything you can to save a patient. Sometimes allowing for them to peacefully pass is a more humane route for every party. While the concept of bringing euthanasia into human medicine is a viable option, the reality is views differ too much, and uncertainty is a powerful factor in maintaining things as they are. I have seen how the act of euthanasia can be a viable medical procedure, but it cannot go into human medicine without a thorough review. We must look at for whom it will be an option, how it will be performed, as well as how medical credibility may be upheld throughout such practice. While I don't feel we are currently at a place where euthanasia should be widely available, we are at a point to begin considering it and working through the unique nature and complexities of every case. Thank you.